Great, thank you all for being here. So I'm going to share our journey over the last 10.5 years, and I welcome questions because we have learned a whole lot and we've done a whole lot wrong, and but I don't consider those failures. I consider them learning points so that I could expand it in a more meaningful way that was sustainable. So I'm going to jump right in. So, you know, we all have heard why telehealth is growing rapidly, but there really are state and national challenges that if you'll know these, you can build your value proposition as you try to roll out your program. And so workforce is a major thing. In Mississippi, for example, our patient per physician ratio is the lowest in the nation. And so we're challenged by not only the rural geographic nature of just access to care, but even just manpower. And so we're all looking at a cost-effective way to deliver care. Additionally, in these small community hospitals and rural areas, they don't see, there's some procedures and some types of conditions that they have low volume of those, but they're high risk. And so how do you maintain the competency of these providers that are out there in the rural area? And then of course they're looking for accessibility and how can I keep these people in my community so that I can maintain viability of my community hospital. So our state is looking at, you know, what are we going to do if really this national movement of mergers and acquisitions are happening and there's really only going to be, you know, 8, 10, 15 health systems. What does that mean for the community hospitals and the critical access hospitals? Are they going to even be there? Do they need to be there? And so how can we use telemedicine in a statewide or even a national approach to address that? So there's a financial crisis, and when we look at these community hospitals that call us and say, hey, would you consider, you know, merging with us or managing us? We have to consider, you know, a bad deal is a bad deal no matter who owns it, but what's the right service for that community? How do you right size the delivery of care there so that it's one you can sustain? But at the flip of that is also considering what others are looking at are jobs lost, and my community is now not going to be somewhere a business wants to move into. So there's multiple sides to this that you have to consider. And then of course we've got to develop and maintain a workforce that's in these communities. And then our health status, we all know Mississippi, unfortunately, we do rank #1 in some things, but it's the bad things. And it's around health outcomes. And so we use the slogan all the time of, if you can do it in Mississippi, you can do it anywhere, because we've got the poverty, the workforce shortages, the poor health outcomes, and how can we do this in a smart way and engage patients? So we actually started back in October of 2003, and some of you will know how funny that picture is on the left, because we had one of those setups for every hospital we connected to, and when you hit the remote control, every camera moved, and so we had to put index cards over the cameras so that they wouldn't do that. And so the room was an L shape of box TVs at that, box TVs and cameras all the way around. So we're a lot more sophisticated than that now, and the good news is that was more expensive than what we're doing now. So things have come a long way. So it's a project evolution, but it's also technology evolution. And so as we're moving more mobile, how do we come up with the technology solution that we're not going to keep coming back to these hospitals and saying, oh, just kidding, now we're going to change to this model and this is the technology we need. Really developing a business plan with those community hospitals that is visionary, because they come to you over one need. I need a stroke neurologist, I need a cardiologist, but they don't even know what is out there. And so you really have to spend time talking through what their long-term vision is, what they want to be for their community, and develop the technology solution that matches that. That's the only way you'll be sustainable. Otherwise, every company that's offering a telehealth service is bringing in another technology solution, and you don't have sustainability. They just cannot afford it. So we now have moved from what was originally 3 hospitals in a pilot program around emergency medicine, and we started for some reason with a 24-hour acute unscheduled service just to test our stamina, I guess. And then have now transitioned to, we have a Center for Telehealth that is integrated into our whole health system, and it is the one portal where all telehealth contracting, technology development, everything happens in that Center for Telehealth. And we now have 32 specialties offered over telemedicine, and it truly is a statewide program. So it really is all about going from volume to value. And this to me was a great depiction that I use frequently, because we went from a addressing a clinical problem in a bricks and mortar clinic with scheduled hours where we respond to a need and fix that, and that's the end of it, to now a virtual, mobile, anytime, anywhere, proactive approach to care. And so it involves this wellness and management of patients in the home setting, moving away and only going to the hospital when you need to. So it's a tiered level of care, and we think it's the most cost-effective one. So this is a real busy slide, and I could spend a whole hour on this one alone. But this has been our implementation strategy. When I tried to go back over the 10 years to think about what was the most important things that we did, I'm going to touch on these, but just know there's so much more to this. But it really is critical to have, whether you're a health system or a clinic, whatever you may be, to integrate that into the strategy of that entity. So for our case, it's a hospital. So I have done my best over the 10 years to truly integrate into the system, so my CEO, my chairmen of my department, before they hire somebody, before they start a new program, they're saying, how can technology play into this, and does it change my structure and my program? And so now that's a standard process. Still have work to be done, but we're getting there. So there's an internal strategy, which is that, and that is, I think, harder than the external strategy. So you've got to educate and constantly educate on every level of provider, as well as IT, your coders, every piece of this that happens for inpatient care. They all need to understand telehealth and be able to come up with a plan in their department. You take for granted all of those pieces from registration, back-end stuff of operations, that if you don't have in place, you'll be sadly awakened to see that you don't have any claims coming back in, being reimbursed and not sustainable. The external strategy, we actually are lucky in the fact that we are the only state academic medical center in our state. There are other health systems, but really we're the trusted partner for all tertiary and quaternary care for the state. So it's a natural relationship, and most of our physicians in our state trained at our medical center. So we've got a lot of trust and a great partnership. But now we're backing up and working with the Department of Health. We're working with the schools, the colleges, businesses. The governor is pushing this harder than anybody, because they start looking at it from an economic development standpoint. How do I get a business into a community? Well, you better have a good education and healthcare system, and those two are priority, or you'll not ever change the climate in your state or your community. And so now we can say, I can bring healthcare anytime, anywhere, so businesses should come. So it's a strategy that he's definitely embraced. Know your customer, and so the customer changes. Every audience I speak to, whether I'm speaking to you all, hospital CEOs, the patient is my customer. What's important to each of them, you've got to know your value proposition and speak to that, because it's a win-win for every one of those. I haven't found a sector yet that can't benefit from that, and from telehealth, whether it's a quality of life, whether it's a parent or me worried about a parent who has a chronic disease and I want another level of monitoring in their home. You just have to find that value proposition and then know what's important to them and how you can sustain it. Proactively bring those things up to your clients and your customers so that they know you understand that this is a financial commitment and it's a partnership, and we both want to succeed. So we've spent a lot of time over the last several months in our hospital. You know, every so many years you hire the consultants to come in and do your 5-year strategic plan. Well, the good news is that they're also helping us to embed telehealth throughout the entire strategic plan. So we're one of the top initiatives for our institution, and we don't see how you can achieve any of the goals of the institution without technology now. And so we're trying to make sure that that's in the forefront of everybody's minds, that technology is the only way, whether your interest is heart failure management or your interest is child development into the schools on attention deficit disorder. We don't think you can scale up and reach everybody you need and control that without technology. So the business plan has to have measurable outcomes. So when we first started this, it was all about filling a gap with a specialty, having the provider there, and that was it. We tracked how many calls there were and all the outcomes like that, but it's really about outcomes to the level that the community hospital wants to know, how many more admissions do I have? How many transfers have I avoided? From my angle, I want to know how many I got. So you got to look at both angles and make sure you're speaking of outcomes and being a good partner to tell them why this makes sense. Because when it comes down to them looking at their budget and deciding what's going to continue the next year, if they don't know you and haven't gotten feedback from you, they're going to cut your program. So it's important to be a real partner in that. And we do a lot of that through just education. We're constantly reaching out to them and through webinars and distance education, trying to build their workforce and so they know we're around. Alternative financial models with your traditional fee-for-service. And so we're all trying to figure out what's going to happen with healthcare reform and what is the models for sustainability. So many telehealth programs in the early days were grant funded. They started and they ended. I will say that we love grants, and that's my last little bullet there, that grants are good, but they do go away. And so now most grant applications do require a sustainability plan, but the reality is you've got to find a way to be able to get reimbursement for this. You've got to find at-risk contracting, different creative methods with the partners of a non-traditional payment structure so that both of you win from this. Whether it's sharing a surgeon that you need to partially fund by them and they're paying for only the portion that they use, or it is an at-risk contract where you both do some kind of revenue sharing off of the activity over telemedicine. And so we've been playing with multiple different models. We still do the traditional contracted fee for service, but we're looking more and more, and thank goodness we were able to get all of our telehealth reimbursement legislation passed. So after July 1, we will have sustainability from the standpoint of professional fees for remote patient monitoring, store and forward, and all telehealth consults, which is huge. So this next one, I'm going to have a slide in a few minutes because this one is even more important. You don't know what you don't know kind of thing. And so you've got to start looking and reaching out to others that have telehealth programs and ask them, what happened? Where did you have your barrier? What was the biggest surprise you got when you were running your program? And find out what those are, because you're going to have them. It may be a little different politics, different players, but you'll have them. So having a strategy around that will prevent you from having an obstacle that could either shut your program down or seriously hinder it. And then of course, grants are good. We use those a lot for pilot projects, but we do not use them in our business plan at all otherwise. So we are completely revenue generating, self-sustaining department in an academic medical center, which does not happen. So we are really proud of that, but that has been 11 years in working. So I mentioned earlier about value proposition, and it's different for everybody of what their value is in this, but if you don't know your customer, you're not going to get anywhere. And so a couple of these are obvious, knowing your patient's expectations. They want it now, they want it easy, they want it convenient, and they want it low cost. But when you start talking about some of the unintended benefits, you may start a program on, child development, pediatric subspecialty, and then you find out your attendance rates in school go up. So all kinds of things, especially around the economic development piece. We have had more and more people tell us, a healthier a healthier environment, healthier community, better workforce, more businesses want to come in. So all of that matters. I started serving on a workforce investment board, and I thought, I don't know why I'm on this. And everything turns back to telehealth because it's access to health care. And businesses are trying to figure out how, as a self-insured entity, do I do cost shifting and keep my employees healthier and bring that health care to them so they stay on the job. Cost avoidance, my CFO hates that word. That's soft money, as he calls it. But it's a reality, and we've got to measure that and be able to speak to it, because the alternative, as penalties increase and as we progress in healthcare reform, it's going to be more important for us to figure out cost avoidance as we have to do things under one fee for management of certain patients. On the outcomes evaluation, we've gotten more sophisticated on this, and I hope we'll get more and more sophisticated, because it's been a void in a lot of the literature. There's great literature out there now, but really looking at the full benefits and outcomes of a telehealth program. And so there's the obvious clinical outcomes. Did I improve the patient's glucose level or hemoglobin A1C in the diabetic? There are very concrete measures where you want to look at the clinical outcome, but then we also want to look at things like ER readmissions, hospital readmissions. And one of my favorite is to compare a rural hospital that uses telemedicine with an academic medical center that has all the resources it could possibly want. And I'll tell you, in our ER program, for example, I had survivability from a cardiac arrest on patients in the rural ER with telemedicine was the same as my academic medical center. That's huge if you think about all the variables that play into transporting patients in a rural area and everything like that. So those are the kind of things that the community wants to hear, the patients want to know about, and then they'll start using their resources in the community, which is huge for viability of the community hospital. The financial one is critical. So what does it really cost to do all of this? And so if it's $5 million for that program, is that even something we can sustain? So you've got to track it. What does it really cost? Know what it would cost if you scaled it up and replicated it, and then be able to speak to that to all of your customers. The humanistic piece, I grouped it like that. It's everything from satisfaction to quality of life. What's important to me is different than what's important to you. And so a lot of pre and post studies, as we're doing remote patient monitoring, we're rolling out a pre-quality of life study, and then we're going to look at it at the end of the year after we've been doing this patient engagement with daily health sessions and remote monitoring. So what does it mean to them and to their family? So that'll be important as we continue this forward. It won't matter if we can't get engagement or if we overdo it and we're talking to them 3 and 4 times a day. And so what if we know they did 12 steps today and 200 yesterday, or whatever, if we're connecting to Fitbits? What's the right balance of that so that it's meaningful information for us, not overkill, and doesn't burn out the patient from the program? And then the process, efficiencies of work operation. And so I think this has been a void too of people not looking at, if I now have a telehealth program in cardiology, if I wanted to replicate all that and do it in person or using my home health team, what does my workforce look like? Did I make people more efficient so they could shift their attention somewhere else? The one thing I think about every time I do this is when electronic medical records really hit and all the coders were in a panic of, what am I going to be doing now? Because the electronic medical records started coding and people shifted, jobs changed, there's still place for them, but really is going to change our workforce and what people do. It won't replace humans, I'm not saying that at all, but it really changes that whole process and work efficiencies. So this is our state, and the green are where we're currently active, blue are rolling out this quarter, and the white, I just haven't gotten to them yet. I will. But as you see on the left, what started as around critical access hospitals and community hospitals now is in clinics, mental health centers, federally qualified health centers, schools and colleges, mobile health, corporations, prisons, and now the patient home. So we really don't see any, it doesn't matter where it is. I do have to consider reimbursement and site of service so that I can make sure I have a sustainability plan. But all of these are ones that I've worked with the insurance companies, or we've worked with legislation to make sure that all of these were covered entities so that we could have a plan that if we bring something that works, we don't want to have to pull it out because we say, well, I didn't get enough money for that. So we've worked really hard on that, and it really has become a statewide initiative. And as I map out population density, I map out hospitals that are at risk for closing, and I map out other strong healthcare entities, then we can overlay where we need to make sure and have multi-specialty e-clinics, and to make sure everyone has access to an academic medical center within 15 minutes of their home, for example. And so when you start looking at it as a statewide approach, but only doing it as a partnership with the local folks, so supporting the community physicians, supporting the Department of Health, and right-sizing it for that particular community. It really does work better when you do it that way than coming in and trying to shove a program into a community and they immediately get the defense up that you're about to take my patients. And it's not about that, it's keeping them there. We're on diversion more now than we've ever been, and we expect that we're going to need them even more. So it's also about back transferring. So once I have this relationship and I brought them to the academic medical center, maybe they needed a surgery. How can I support that community and our own institution by back transferring them and supporting them through technology? So multiple avenues, multiple perspectives, but one that really is required to be able to sustain your program to have multiple approaches. So we do have a 24/7 call center. This has evolved as well to where we had our nurses who were doing the ICU covering it to now we have a telehealth coordinator. And so they answer the calls, they schedule telehealth consults, as well as if it's a stat call for one of our emergency services, they'll push that immediately over. And we have integrated this in with our medical communications center as well. But it's where we can also schedule education, and it's the one number that everybody knows to call in our state for telehealth. So it's about, that part was about being convenient for our end user, the hospital there. If we tell them to call this number, then fill out this form, and then fax it over here, you're gone. That's out of the question. They don't have enough resources. So having the call center, we do all of the work for them. And then it's about being convenient for our providers. So our physicians are busy too. And so if I come tell them they need to staff this, and then this is what I need them to do, and it's some long list of objectives that's different from in person, they're not going to do it. So we really try to make it as turnkey as possible. When I'm going to add a service, I ask them, where do you work? Where do you want to do these consults? Do you need more than one location? Do you need an iPad in your pocket? So we use iPad minis, we have desktops in their offices, we have them in the units where they work a lot. And so they have multiple places where they can just step right in, just like it's another exam room in their hospital. So this is our child development specialist, the only one in our state that covers in telemedicine. So it says goals for Mississippi, but this is really goals for anywhere, national telehealth agenda. And it's about increasing access points, and that's becoming more and more mobile. So I've been talking about e-clinics, but we're going to be using the phone more and more. And so what is the balance? So it's almost a tiered approach. First level is let's check in on the phone and almost triage to see if we can handle it on the phone. Then maybe you go to a multi-specialty e-clinic. Then maybe you have to go to an academic center. You just could tier that. We can't do everything the same. We'll go broke trying to do that. And we'll also miss people. So it's a risk stratification of your population and right sizing the technology and the workflow around your telemedicine to match the needs of the patient, but having more access points. Utilize existing resources. So as the Department of Health is trying to figure out, what do we do now that we were the safety net, and now with healthcare reform everybody is insured, theoretically almost. So what do we do? What are we? And so as I'm building a population health management program in my state, I don't need to go hire nurses and coordinators all over the state. I need to use them. So partnering with them supports them, you get buy-in from them, and then it also helps me, so we all win. So utilize your existing resources where you can. Politics are difficult, I won't lie, but it makes for a more sustainable program with champions that are also singing your songs, saying telehealth is great, we love it, it works. If you start taking jobs, you will find some roadblocks. Building capacity. So this is something I think every telehealth program is challenged with. When you go from scheduled consults to a 24-hour operation, how do you keep up with the demand? What do you do when one physician quits? How do you build your model to have the capacity you need so that you don't have a breach in that service delivery to your patients? And sometimes it's partnering with someone else to provide that specialty care. Sometimes it's us offering that to another institution and trying to build consortiums of telehealth providers around your state. Whether that's out of state, big groups, there's lots of them. Many of them are even here today. But you do want to have a plan around your capacity building to meet the demand of your patients. And then I can't emphasize the last one enough, of your relationship building. I'll never forget, recently I was presenting at a corporation that already had a medical clinic on site. And this is recently, and the physician had a demeanor at the very beginning where I was like, oh, this is never going to work. And toward the end, I kept saying, we're here to augment, to fill gaps. And I've used that a lot, but it had not had anybody turn around, and he specifically said, I'm so glad you're saying it like that, because I'm sitting here coming in with a solution that could really replace them. And so they want to make sure you're filling gaps and building the right model for the state. And then of course collaborating with all kinds of entities from your legislators and governors. Find out what's important to them, find out what is important to the clinics and health system and schools, and build a program that makes sense for them. It may start as an educational contract to use your web conferencing for that, and then building it into the next level, and be patient as those relationships build. And then of course, our Mississippi Delta is one that has lived this way too often. Grant money comes pouring in, they start great programs, and they all stop. So we have not had to stop any of our programs since we've started this, and it's critical to be able to have buy-in from your community. This is another one of my favorite slides that could take an hour. So as you're rolling out your program, the barriers, the challenges, much of which what ATA speaks about and some of their policy papers that are out there, are around these, and every one of them you will have to navigate through, and every one of them are a little different in every one state. There's work being done at the federal level around the licensure and FDA work, but there's a lot around your local level that you've got to be familiar with. So as you're doing these contracts and credentialing providers, you need to understand your Department of Health standards, you need to understand the bylaws and the exec board bylaws, to know if they're going to accept what you're planning. So it's easy in some hospitals, and others it's not so easy. And so all of these issues are critical for you to know about and understand at an intimate level in each state that you're working and doing telehealth. E-prescribing is a great example. In some states, you can talk to a patient, get their symptoms, and e-prescribe. In others, you can't. You got to have that patient-provider relationship. In some states, that can be obtained through telehealth and a consult that way, and other first visit has to be in person. And if you don't stay on top of that and monitor it, you won't know, because it's different in every state. I think the biggest one right now that you hear everyone speaking about is the licensure issue, and there continues to be a lot of work around that, and some federal policy and legislation that's active right now from Harper and Congressman Harper and Thompson, that both have legislation out about that. So this is our recent signing about 2 or 3 weeks ago, I guess, where we signed into law our telehealth reimbursement for remote patient monitoring. And I will get a daily fee to monitor patients in the home setting, as well as be paid to set up that in their home to educate them, as well as storing forward. But what I want to say with this about the challenges is that even when you pass that, you get so excited, and then you're like, okay, it's going to work. It doesn't work. Oh my gosh, you have to go and meet with every insurance company. You have to help them write their medical policies. You've got to teach them the coding. Then you've got to go around the entire state to everybody that's going to bill for this and teach them how to do it, or otherwise it's not billed. No one codes it right, so either you inaccurately under-report how much telehealth's going on, or you're over. It's not accurate. And so how are you going to go back to the insurance companies to say you denied 45% of our telehealth and start working on those policy and changes if you can't even speak accurately about what's going on in your state? And I'm still challenged with this. So last year we had it signed for just telehealth consults, parity language around that. And we're still working on that. I still have to track it and report to them. But you've got to engage your legislators, and this bill right here passed 127 to 0 because they understand it. And that was no easy feat. You have to go talk to them, and when they say, I don't want that, we don't need that, and I say, guess what? Your constituents in these two areas that you cover receive telehealth right now. They don't even know. So have you asked them what they'd feel about this if you took it away from them? It works real easy when you do that. So our governor has helped lead the Diabetes Telehealth Network, which we actually kick off for the first day of enrollment on June 2nd. And so I hope to be able to report next year outcomes. But this is one where we're actually going to send patients home with a tablet, a cradle, and an air card so that the tablet works no matter where they are, because it'd be no good if I sent them home with a tablet and they couldn't connect. And we will have it combined with telehealth. So their local community clinic will have a telemedicine connection to us for endocrinology, ophthalmology, dietitians, nutritionists, you name it, the whole team. But we will also have sessions at home so that we can monitor them and intervene earlier. We will push education, we can do videos into the home, we can do the whole bit. So we're going to study this and actually see what happens and great if it happens, but can we afford to replicate that? And so it'll be interesting to find out how much can be on a phone with just a phone call, or how much needs to be done over a tablet or some kiosk device in the home. But it's about right sizing that. So there's going to be a level of care we can do in the home, but we're going to have to partner with those clinics and have telemedicine equipment there as well in the hospital so that they can follow the right level of care that they need. So these are just a few more that the governor has supported and the state has. So we found out what the pain points were in our state just by asking, what's the problems here? What is your platform issue that you want addressed? And then we grabbed hold of it to say how telehealth could answer it. So e-corporate telehealth, this was actually funded by our Mississippi Development Authority and the governor's office for the first pilot to bring on 8 corporations free of charge. We're going to give you unlimited telehealth consults for urgent care. Only catch is you have to be a good partner. I want to know everything you spend for your health care of your employees, and I want to compare it before and after. And then on January 1, this is the cost of it. So we're going to show between now and then. I'm so confident in this program, I'm okay with this. In January, I'll let you know how that goes. But so they are using this, and we're building it around their needs. We do health fairs, the whole bit, but their safety nurses and safety officer and nurses are facilitating that at the corporation level. School health initiative. This we have a pending program that we hope to hear about soon that would put telehealth in every school in our state, and we would work with the school nurses to do behavioral health as well as medical management of the kids in the schools. Again, not taking away anything that's there, but augmenting the nurses that already exist. Statewide Alzheimer's network, we're rolling out July 1. We have, I think there's 2 Alzheimer's centers and dementia centers in our state, but they all really come to our medical center. So we're going to have e-clinics around the state. And then population health program, you hear this a whole lot. You hear everybody talk about it. Everybody means something different by it. I'm going to tell you what I mean by it. I mean risk stratifying your patients, knowing claims data, pharmacy data, electronic medical record information to build a whole picture so that you treat the patient in a tiered approach. So if you have a diabetic, they're not all treated the same. Some may need no help. They may be completely controlled. Others are a brittle diabetic that's coming in and out of your ER in your hospital, and they need a different level. But you've got to know your patients, and otherwise we're going to roll out a one-size-fits-all, and we're going to go broke doing that. So that's an important program also. So Alliance for Connected Care, Center for Connected Policy, and ATA, we actually had McCarthy, Senator Lott, and Congressman Harper down a few weeks ago also. And it's constantly inviting these people. They actually will come. I mean, who would have thought they'd come to Mississippi? But when I call and you ask them, hey, look, we want you to see what telehealth is doing in Mississippi and what the outcomes are. We want you to see this and take it back to California and talk about it there too. And get additional sponsors for these bills that are going to help us advance that. So ask them. If you have a program, bring them, talk to them. Go to DC and talk to them as well. They want to hear it. So, and just along the same lines around the federal support, these are just some of our projects. So I said grants are good, but, well, I still participate in all of them. So these were this past year, and as you see, there's like the DLT, for example, they continue to keep funding us. So if you have good outcomes, I invite them down. I'll call them and tell them, hey, come down and see what's still going on here. Show them the outcomes. They get really excited about that, and they want to fund you again. So lots of different sources of revenue to be able to test programs and get equipment out to these places. A lot of times the biggest barrier is your capital cost for the first setup of that telemedicine program. So if you can help cover that, we actually own every telemedicine piece of equipment in our entire state and our program. We own it, we maintain it, and we support all of that. And that's been a huge help to our program. So I'll close with this to say kind of where we're going. And again, it says Mississippi, but it's really about any program of where we're going. And this is just our forecast that as we're getting more and more mobile, that we're going to start risk stratifying these patients and not having one size fits all, that will bring health care to them, but to the right level. And that we'll find out that balance of how many visits it takes at home, for example, to keep a heart failure patient healthy. And build a model that really is one we can sustain and scale up, and it's meaningful to each of the patients and their particular place in health. because the patient will move between those levels of stratification. So I might be low risk now, but in 6 months I may be an at-risk or even a high-risk person, and you'll go between those, but we need to be able to adjust our program to match that. And then it's all about right sizing, and so getting in the community, knowing your state or your region or your whatever territory you're working in, and building the right model of care. What is the healthcare delivery model for that area, and using the technology to the right level. So thank you very much. I'll take questions.
If you have any questions, let us know, and I'll bring the microphone.
Kristi, it was excellent. Thank you for coming.
Thank you.
And thank you.